At the School of Medicine. He went to medical school at University of California and went on to get his master's in public health at University of California, Berkeley. He's done work down in Oakland and up here in Seattle, mainly focusing on adolescents and that sort of stuff. So without further ado,
mainly adolescents with eating disorders, but I also see a lot of males, adolescent and young adult males, and I also run a transgender clinic. I do transgender hormone transition for adolescents and young adults. So I'm grateful to be here. I really want this to be, I've just heard about this class and I'm really happy that I'm here. I think I'm going to be speaking to the choir a lot of the time, but if I'm not, that's fine too. I hope I give you something that you can understand. And since these are dental students, I have Invisalign, and sometimes my mouth gets dry. and I have rubber bands and all that stuff, so if you don't understand what I'm saying, just let me know, okay? So there's a couple of things that I'm going to talk about today. I'm going to talk about kind of the whole, how being LGBTQA, whatever that paradigm is, it's a natural progression of a normal, healthy sexuality. A lot of times people, so I just want to make sure I give you all the three outcomes. So I'm going to talk about three risk factors that are faced by these young people. I'm going to talk about ways that homophobia itself can contribute to the LGBTQ health outcomes that some of these young adults and adolescents face. And then lastly, I'm going to talk about three elements of competent or aware healthcare delivery for this population. So what is sexuality? Well, sexuality is a normal developmental milestone that every one of us go through. A lot of times in this larger population, we don't think. Society, they don't see adolescents as sexual beings. Adolescents aren't supposed to think about sex, aren't supposed to have sex. But they are, they're thinking about it, and they are having sex, and it's a normal developmental milestone. Just like their identity as a person, their sexuality, their even if you look at even with racial identity or cultural identity, it's a normal process. Healthy sexual expression is different than sexual risk. A lot of times our society puts them both together. If you're having sex, you're having, if you're young, you're having risky sex. Well, many times that could be true, but a lot of times it's not. So, trying to understand that an adolescent, when they are having sex, it is a normal process that they actually go through. And then if you look at same-sex sexual behavior, it's definitely included in the realm of healthy sexuality. And I put this up in that one of the reasons why I went into adolescent medicine is that young people are resilient. They can go through a lot of different things. They face a lot of developmental milestones, and anywhere in that process, something can happen. It can lead to some abnormal process. But the majority of adolescents will get through adolescent developmental period unscathed. And so, knowing that this group itself can have can lead normal, productive lives. They usually develop resistant adaptations. Now, some of it may be a little abnormal, but some of it is normal. Like, as an African-American male going to medical school, I was pretty much the only African-American male in my class. Jokes, questions. I adapted, in a way that sometimes I made things funny, I made things light, because I knew some of the people that were making some of the comments didn't really mean it that way. And so, and that's an example of some of the things that some of these young people do. They adapt in a way that is comfortable for them. And the majority of the time, it's fine and there's no kind of mistreatment that goes on. But there is some that occurs. So the effects of homophobia. So, a lot of times with racism, with homophobia, with, sexism, genderism, etc., if you don't have some of these normal adaptations, you're going to internalize it, and it's going to kind of fester, and really kind of blow up within the person. And it leads to a lot of different things. It leads to them not liking themselves. It leads to them as a risk factor of self-medicating themselves, mainly by using substances, and that can lead to substance abuse. It can lead to shame, self-hatred. They don't really like themselves, and a lot of times they stay in the closet, and that's where some of the the risky behaviors that, if you look at sexuality, some of the risky behaviors kind of is an offshoot from. And then the risky behaviors as far as them not really liking themselves, leading to depression, and then leading to suicidal ideation or suicidal thoughts and actual suicide. So, a lot of times there are barriers within our own healthcare system. And I have some study questions that I found maybe about 5 years ago that kind of highlights some of the barriers that we see. So if you go to the doctor and you're not asked about your sexuality, and you're, a physician or a nurse practitioner or a physician assistant or, a dentist may ask some of these things about sexuality. They may say, oh, how's your girlfriend or how's your boyfriend? Not knowing that that person is the same gender-loving individual. And that, if that patient does not correct them, it festers. It festers within that whole visit, and sometimes they just tune you out. And so the message that healthcare provider is trying to give is lost, unfortunately. So one thing about adolescent medicine, we really try to achieve confidentiality. They've done study after study after study. And the thing that adolescents really desire is they want confidential care. They want to be able to talk to you in a way that they feel comfortable and that you're not going to go and tell their parents. And, luckily we live in a state that allows for, reproductive health, substance abuse, treatment, mental health treatment, that they can get those services without letting their parents know, because, sometimes parents don't understand, and could lead to a lot more depression and suicidal thoughts. One thing that I learned in medical school was that sometimes I'm a very expressive person when I'm excited about healthcare, about taking care of a patient, or something is like, I couldn't go into dermatology because I will make a face like, ugh. So this is important, because if you come out to if the young person comes out to you and you have that kind of disapproving face, that, oh, okay, that translates into that you're not understanding. And again, that visit is out the door. And then again, provides assumption of heterosexuality. I think that is the single most common thing that we all do sometimes. If we're busy, we have 6, 7, 8, up to 15 patients in that day. We're running late. We don't kind of delve into some of the deep things that the patient is doing, and sometimes we miss it. But that is the single most thing that causes a lot of that homophobia and the barriers that they actually get when they go into the healthcare system. And then they feel guilty. They feel guilty that they either didn't say anything at that moment, or they feel guilty that, I've done something that I want to talk to my provider about, but I can't tell them. So one thing that I tell people to do is kind of create safe spaces. And, I got this off the internet, but, there's a bunch of them like this. And, having signage, having literature, having magazines within your office that people can see tells them that, oh, God, I'm welcome here. This is somewhere that I probably will feel comfortable. So it all starts with also, you have the outside, the environmental piece, but training your staff. It took me, I work with adolescents and people who work in adolescents, and even in pediatrics, they kind of are in tune with peds and, adolescents. And so it was pretty easy to train my front desk person to ask about what gender pronouns patients want, etc. But you have to train your staff to know that there are different people out there, and they may have, certain different expressions, either their sexuality or their gender or their physical expression about how they're feeling inside. And so teaching them makes it a better, safe environment. And then, of course, assure confidentiality. That is key. And then, providing support resources. If you don't know of any support resources in your clinic or in your wherever you are, find them. And I have a long list of support websites at the end of this talk, and you're welcome to them. But have them handy. Have them where you can actually use them, or if you don't really know about them, call these places up and ask about their services. And then have a zero tolerance for insensitivity. It stops at one time, and that would be it. And then that kind of breaks that cycle. So one thing that we have to do is we have to understand our own personal biases. Even if you look at some communities, particularly the LGBT community, the lesbian community, the gay community, bisexual community, even though we lump them all in one group, they don't understand the intricacies of the other group. And it may be difficult. There may be people who are identified as gay that don't quite understand bisexuality or don't understand, transgenderism. And so, and if you're not even in that group, trying to understand that whole alphabet soup about who these people are is quite difficult. So you have to kind of understand your personal biases. Like maybe you just don't understand. I support people for who they are, but I just don't understand. I'm scared that I'm going to say something that might be offending to someone. So understand your personal biases. Providers, who are uncomfortable about doing things, patients see right through it. If you're going to do a dental procedure and you're a little nervous, that's going to make them nervous. If you're going to talk about, safe sex practices, and you're a little nervous about how to do it, they're going to be nervous because they're not going to trust you. So, I think the key thing is, as a provider, it is your responsibility. If you don't feel comfortable and you don't feel like you know a lot of the resources, I would say it. Say that you don't know those resources, but I want to try to find a place where you're going to get the health care that you need. So this is basically the paradigm of sexuality. You have sexual attraction, you have sexual orientation, you have biologic sex, you have sexual behaviors, and you have your gender. It's all different pieces, but that they intersect. And a lot of times when I have families come in and talk to me about my trans patients, they would say, oh, I thought my daughter was lesbian, or I thought my son was just gay. I said, well, that's their sexual orientation, maybe. That's not their gender identity. So all of those pieces play a part in the paradigm of sexuality. So if we kind of focus now on gender and identity and expression, a lot of times, well, all the time, we are assigned our biologic sex, male or female. If you have a vagina, you're a female. If you have a penis, you're a male. Now, there are individuals that are born with ambiguous genitalia, and that is always an issue, because how do you assign them? And now, thank God, we have clinics that specialize in that. That it's not just, they don't choose right then and there what that individual's biologic sex will be. But their biologic sex is basically their physical out manifestation. It's not who they feel they are inside. So if you look at all the different, the gender and sex, it's always a spectrum. It's always as far as how people behave, people's characteristics. It's a spectrum between, male, female, as far as natal sex and their anatomy, because we have those disorders of sexual development. Gender identity, you could be right in the middle or on one extreme or the other. Gender expression, how you express yourself in how you dress, how you talk, how you wear your hair, and your sexual orientation. There's a spectrum. So if we look at transgender, I gave you a handout on some definitions and terms. But generally, those who identify who are biologically male, who become female, are termed transgender women, but they're also termed MTF. And the opposite is true for females to male. They're transgender males or F to M. And that whole transition of changing from their gender identity from one sex to the other is called your transition. And it's that process, that time that it takes to transition to the other gender. So how do you ask this stuff? I think, well, one thing, if you look at your standardized forms, it'll either say male or female. If you look at health records, it'll automatically assign your sex based on your health records. So it becomes difficult. So when you look, you have a 15-year-old or a 20-year-old female here for some dental procedure. You're going to assume that they are who they are, but if you don't ask, you're not going to know. So one thing that you can ask, if you don't have it in a paper form where people can put whatever their gender identity will be, you can ask, as a person, how do you describe yourself, as male, female, or both? And the same thing with sexual orientation. So with sexual orientation, it refers to their physical and their emotional arousal toward someone else. And so you could be heterosexual, and that's attraction to the opposite sex, as you know. And homosexual, you could be gay or lesbian, bisexual. And then there's this group of people who are pansexual. They don't limit themselves to one sex or the other, which, I'm hearing more of. And then queer. Queer, when I was your age, it was a derogatory term. But now it's something that our young people actually really embrace, and it's somewhat of a umbrella term of this kind of different gender expression and attraction. And then there's other. And we could talk about some of the others. So, discussing someone's sexuality. If you don't ask, you're not going to know. It's very, it's invisible. They don't come in, commonly, unfortunately, people have these stereotypes of how people dress or are supposed to dress. If there's a young man that comes into your clinic and they have makeup on, a lot of times the assumption is that they're gay. But sometimes that's not the case. Sometimes they could be bisexual, or they are heterosexual, but they enjoy wearing makeup. So a lot of times it is, you're not quite sure, but a lot of times it's invisible. You don't know someone's sexual orientation unless you ask. And there's different ways that you can ask, depending on depending on their cognitive development. Now I see adolescents from 11 to 12 up to 24, and depending on their cognitive ability, sometimes they're still very concrete thinking, sometimes they're very abstract. So if you have an adolescent, depending on no matter how old they are, if they are very concrete, you want to ask them in a really concrete way, such as like if I have a really concrete individual, I say, how do you imagine yourself? Do you imagine yourself romantically involved with a male, female, or both? Or do you see yourself marrying someone of, male gender, female gender, or both, etc.? If they have abstract thought and they're, they can understand a lot of the kind of abstract thinking, you want to say, are you attracted to, because the attraction sometimes could be, oh, I'm attracted to them because they're my friend. But if you put it as I'm attracted to you, or you ask them if that are you attracted to men, women, or both, that kind of connotates that they are attracted to that sex or not. So we look at behaviors. So this compares gay, lesbian, and bisexual youth compared to heterosexual youth. And as you can see, more GLB youth have ever had sex than their heterosexual counterparts. Also, they tend to have sex younger. In addition, they also tend to have more sexual partners and use alcohol or drugs at their last sexual encounter. So even though I said at the beginning they're resilient, a lot of them go through, adolescence as an LGBTQ individual unscathed, but there are some risky behaviors that can lead to a lot of damaging things. So this is what I was talking to you about. This is from a study about 5-6 years ago that looked at healthcare providers. And mainly they were physicians, but they were all different types of physicians. There was pediatrics, there was OB-GYN, and there was internal medicine and family practice. So, one of the questions was, what percentage of physicians believe that they would assume all patients are heterosexual unless otherwise told? What are your thoughts? I can't hear. 55? I heard 55. Anyone? You guys agree that's probably 55? It's actually 22%. Okay, we're going to try another one. So what percent of physicians include sexual orientation and sexual histories for patients at any age? Now, again, this is not Washington State. We're talking about other states here. Okay? Maybe that'll help you. What are your thoughts? 12? Actually 32%. Okay? What your numbers are getting closer. What percentage of physicians would identify 3 major local resources for LGBTQ, like, even a homeless shelter if someone has been kicked out by their parents, or a STD clinic, or like we have something called Lambert House here, like a place where they can go and get resources. What percentage would know of a place? 37? I heard 57 and 37. It's actually 17%. So, again, I believe I'm speaking to the choir, but if the people who actually need to hear this talk are not here, unfortunately. And so I need you guys to kind of spread the word. So we talked about asking, about sexual orientation. The whole process of coming out, I think that's one thing that a lot of providers feel nervous about. How would they handle it if a young person or even an adult came out to them and no one else knew? And then just imagine what happens when the young person is dealing with or trying to come out. It can be very, very, very hard thing. And when they approach you, that they haven't talked to their parents or their family, and they're thinking about coming out, you want to ask them what their feelings are. They know their family and their peers better than you, because you may not know them as well. So kind of assessing their comfort and feelings about themselves and about coming out is key. And then, is there anyone that they feel like they can disclose to? And if not, it could just be you, and until they're ready, it could only be you and themselves. But identifying someone that they're close to and maybe doing some role plays with them or how to tell that person. It's something that we often do. And then counseling them around consequences of disclosure. Now, we're going to see some of these statistics, but there was a study that came out of San Francisco looking at youth in the Mission District. And that they were ages about 14 to about 21. And they looked at a subset of LGBT, mainly gay and lesbian youth who came out to their parents. And a subset of them had depression and a subset didn't. And the subset that actually came out to their parents and they were supported by their parents, either they never had depression or their depression got better. Those who came out to their families and they were rejected, they had increasing symptoms of depression and actually increased suicidal thoughts. So family rejection is a really key piece in this. And there was a few of them that I would say about 3 to 4%, if I can remember, actually became homeless because they were kicked out by their parents. So talking to them about what is the risk, if there is any risk, maybe counseling them that this is not the time. Can we talk about this again? Can I give you some resources on who to talk to when the time is right to come out? So common misconceptions, as I mentioned earlier, orientation is not always behavior. By saying I'm a gay male doesn't mean that I'm always going to have sex with men, okay? Vice versa. So you can't always look at that orientation and predict their behaviors, their sexual behaviors, because often it could be different. So this statistic, majority of women who have sex with women have had sex with a man. Okay? And so gender identity and orientation can be confusing. Now, it really gets confusing when in my transgender population, I have a trans female who is attracted to men. And so you're thinking, oh, well, they might be gay. Well, no, her sexual orientation is heterosexual. Or, I would say heterosexual. But opposite is true. You have a trans male who is attracted to men, his sexual orientation is gay. So it can be really hard to explain to families about how that works, and it can be really hard to comprehend as you're taking the sexual history. So looking at contraceptive use, particularly in lesbian individuals or bisexual, young women who identify themselves as unsure or bisexual of their sexual orientation, almost all were twice as likely to report no contraceptive use at their last sex. Same thing with our gay men, bisexual men. A lot of times they don't use condoms because they don't view themselves as gay, and so they don't see them as getting the risk that a gay man would have. So pregnancy risk. When compared to heterosexual youth, lesbians and bisexuals are as likely to have sex, meaning intercourse, and they experience twice the rate of pregnancy. So because I believe it's the same process, they're doing the sexual behavior, but they don't have that emotional tie, and they don't think that they're going to get pregnant, and a lot of times they don't use contraceptive. And they're also more likely to have 2 or more pregnancies than their heterosexual counterparts. So STD risk with women who have sex with women. So nationwide, there was a study that looked at women who are self-identified as lesbian. About 17% reported a past history of STDs or STIs. And the culprits tend to be trichomonas, HPV, human papillomavirus, bacterial vaginosis, and HIV. So STD counseling, you have to know their behavior to know how to counsel them. An example, I just saw one of my patients who is identified as a gay male, and he said that he had unprotected sex. I could have left it at that and gave him a cup and had him pee in a cup for chlamydia and gonorrhea. That's a common way of testing for chlamydia and gonorrhea. Well, I wouldn't have found the chlamydia and gonorrhea there because he's having oral sex and he's the receptive partner in anal sex. So giving him a cup to give urine for testing for chlamydia and gonorrhea, I would have missed the boat totally. So you got to know their behaviors. So, looking at back to lesbian women or bisexual women, teaching about sex toys. If they're going to use them and share them, they should wash them after each use. They could use saran wrap or dental dams, etc., to decrease the risk of any transmission. They can use the flavored male condoms, etc. So back to the issue of coming out, a lot of times there are that rejection from their peers and their family, which can lead to this family discord, homelessness. They feel this religious condemnation. They get rejected from teachers that they have been close to or peers. There's victimization. A lot of them, the Youth Risk Behavior Surveillance Survey is a survey that happens in each state that survey high school students. And if you identify, not all states ask about sexual orientation, but those who did, those who identified as gay or lesbian or bisexual, a lot of them had high rates of avoiding school, bringing a weapon to school, or having been harmed at school that required a ER visit or urgent care. Social stigma. Feeling isolated, that no one else is like them, especially if they're in imagine if you're living in a rural area where there's not a whole lot of people that you can identify with. So these youth in mental health, they're 2 to 7 times more likely to attempt suicide. Now this is compared to heterosexual youth. And they're 2 times as likely to report depression. And men who have sex with men are more likely to suffer body image issues, and actually some of them develop eating disorders. So safety and risk, 28% of them drop out of school because of harassment. A lot of them, they don't feel comfortable going to their schools. About 25 to 40% of homeless youth identify as LGBTQ. And then there's an increased risk of bullying and harassment. 84% of those have verbal harassment. About 30% report being punched, kicked, or somehow injured. And this is at school. 55% of trans youth report physical attacks. If we look at these youth and substance use, so there was a study that looked at in the last 30 days, asked a subset of LGBTQ youth. These youth were more likely to have used tobacco, alcohol, and cocaine compared to their heterosexual counterparts. And then those youth compared to heterosexuals are more likely to use substances less than the age of 13, tobacco, alcohol, and cocaine. So and this kind of goes back to the self-medicating, the shame, the depression that can occur with not feeling comfortable with oneself. So looking at the CDC guidelines for screening, for STI screening for women who have sex with women, it's recommended that Pap smear and chlamydia screening is done based on their guidelines. So for Pap smears, 21 and up, okay? So we don't do Pap smears routinely on women who have initiated having sex, particularly intercourse. So at 21, and then chlamydia screening, if you're at reproductive age and you're having sex, at least annually check screening for chlamydia is the recommendation And then, routine screenings is not recommended, but if they are showing some risk behaviors, you have to think of these other ones: trichomonas, BV, HSV, which is herpes, human papillomavirus, HIV. So the guidelines for men who have sex with men. So the recommendation is that we screen for HIV and syphilis, and depending on their risk behaviors, meaning if they're having multiple partners and they're having a lot of unprotected sex, you screen them more frequently than those who are not having a lot of unprotected sex. And so this kind of goes back to what I talked before. You screen for chlamydia and gonorrhea from the urethra by urine test. And it's for those who are having insertive sex. So they're the insertive partner in the relationship. Rectal, you can do gonorrhea and chlamydia by a swab. And of course, you would screen someone who is the receptive partner with anal sex. And then also you can screen for gonorrhea from the mouth. So here's some information about men who have sex with men and condom use. Among young men who have sex with men, about 27 to 48% have engaged in unprotected sex in the last 6 months. Now, I had a patient, one of my transgender patients, 18 years old. I transitioned her at 16 years old. I've been seeing her, initially every 3 to 4 months, and now I'm seeing her at least 2 times a year. And we talk about safe sex, we talk about risks, etc. I saw her yesterday, and I asked her about, are you having sex? Are you, using condoms? She said, yeah, but I didn't yesterday. And it was the same partner, had sex 2 days ago with a partner, used a condom, but the next day wanted to have sex, didn't have a condom, chose to have the sex. So even, somewhat older adolescents have had the education. Sometimes you could have to continue to educate them and screen them. And I wouldn't have known if I was just concentrating on the hormones. I wouldn't have known that she had this unprotected sex, and I wouldn't have screened her. I would have just let her leave the clinic if I didn't ask. So counseling about condoms, there's a lot of reasons why, condoms aren't used. And I want to urge people who talk about this to talk to them about it. Don't say, oh, you're going to get STD, you're going to get HIV, etc. But you want to know why. They may have a rash after using latex condoms, or no one's really taught them how to use a condom. That happens a lot. They won't tell you that no one's taught them, because they'll say that they know how to use a condom, but a lot of times no one's really taught them how to use a condom. So withhold judgment, respect concerns. All condoms will fit on all size penis, but if they feel that it's too small, etc., it's okay to go with that and offer different sizes, different colors, different shapes, etc. So, we talked about, 3 risk factors. We talked about homophobia, how important that is. We talked about health outcomes, our health, competent health, healthcare elements of delivery that are important for these young people. Now, this is what I've talked about. I'm sorry you can't really read this, but hopefully you can have my slides. But these are some provider resources that you can give to people who don't know, or you can keep them yourselves. This is national resources. And then there's some family support resources that are up here, PFLAG and the Family Project at San Francisco. And these are some local resources. Lambert House is a really great resource. Also, we have a lot of great educators for our homeless youth at Country Doc. So if you have homeless youth, you know about the 45th Street Clinic. And if they don't know about it, you tell them about it. If you know that they're in the Capitol Hill area, the Country Doc, which is on Mondays and Tuesdays, will be very helpful. So I want to leave time for some questions.
When you ask a patient to identify gender on your health histories, what options do you give?
So, You mean a written form or
Yeah,
verbal?
yeah.
So I'll give M, F, M to F, F to M, other. Some places I've seen have queer. Or, easy, you know, gender, blank.
Yeah.
Then they can write it in. So bisexual means that they are attracted to both male and female people. Pansexual, they're attracted to male and female, trans male, trans female, drag queen. Yeah, pan. Any other questions? All right, thank you.